So this will be Lab 10, Respiratory and Urinary Systems. At the beginning of the lab, we watched a video, which I'm now able to record for copyright reasons. And you have been looking over page 519 for those structures. I want to spend just a couple of minutes taking a look at the PowerPoints that I did not go through and basically look at the pretty pictures. And so if I look at this image, and you have these images, if I look at the respiratory system, I can appreciate that it can be divided up into the upper and respiratory tract regions. And the way to remember this is very easy. The lower respiratory tract starts with the larynx, so LL. So the larynx, the voice box, is the first part of the lower respiratory tract. So easy enough to remember that. Now, go down a few more pictures, and we're going to see now what looks exactly like your mid-sagittal cut of the head. Okay? So when we're looking at this, let me just point out a few structures on here. On here, you are able to see only two sinuses. You can see on here the frontal sinus and the sphenoidal sinus. You are not able to see the ethmoidal nor the maxillary sinuses, and you'll see why in a moment. I'll show you a different view, a frontal view, and you'll see why those sinuses aren't visible on this particular section. They are, in fact, spaces within the frontal bone and spaces within the sphenoid. And you can always tell the sphenoid because you're going to see right next to it what structure, what bony structure. The sella turcica. Remember, the sella turcica was that Turk's saddle that holds on to the pituitary gland. So you'll see that little sella turcica right next to that sphenoidal sinus as a reminder that you're at the sphenoid. Also, when you look up the vestibule, right, the opening into the nose, and that's on your list as well. And we look into the nasal passages, and we're only looking on one side or the other. The septum is not shown here. And we see these shelf-like structures. One's called the inferior nasal concha. Now remember, you had a bone, right? The inferior nasal concha. It was a bone, a pair of bones on the lower side of each side of the nose. And imagine now that there's skin, right, over that bone, those bones. That creates this lower inferior nasal concha. And then there is a middle and a superior nasal concha. And those are bumps of part of the ethmoid bone. The ethmoid bone, remember, comes down and forms some of those nasal concha. Now, in between those shelf-like structures are tube-like passages where air flows through. And those tube-like passages are called meatuses. You know what a meatus is. Remember the external auditory meatus, that tube-like passageway for the ear canal. So we have the meatus now passing between the concha. In a few minutes, we're going to look at a video, a very short video, but you're going to see a laryngoscope be placed through someone's nasal passages and down above their vocal cords. And you're going to notice that that laryngoscope is going down what looks like a very narrow path through the nasal passages. And you're actually going through that meatus between the concha. In the nasal pharynx, there's the pharyngeal tonsil, right? The adenoids, they're on your models as well. And right here is the opening for the auditory tube. Remember, that's the eustachian tube, the tube that's going from your throat up to your middle ear. It's also called the pharyngeal tympanic tube because of where it's traveling. And you can appreciate now, if you're having a lot of infections, ear infections, that those bacteria would be draining and coming out right next to the pharyngeal tonsils, which that would now make your adenoids to be inflamed and angry. And so that whole ENT cycle of ear infection and adenoids and tonsils, you can begin to appreciate the proximity of those structures and why they are so connected. The soft palate, we've seen this before. The very tip of the soft palate is called the uvula. And on either side of the uvula in the oropharynx would be the palatine tonsils, right? In the soft palate area of the oropharynx. We've seen the epiglottis before. We know about the epiglottis. Before we talked about this in regards to the digestive system, and we talked about the epiglottis protecting the food from going down the trachea. Here we imagine the epiglottis staying upward, if you will, and now air is able to travel down into the larynx, down into the trachea and the lungs. When you're in the larynx, you're going to see that little fold. Looks like that. And you see that in your models. You all have a trachea on the stick. In fact, you have two of them. You have the one on the model, but you also have the larynx that pops off the long model. And it does the same thing. They open up, and when you look inside that model, you're going to see that little, I'm not sure what you would call the shape, right? But this shape. And the upper fold is the false vocal fold. And it's also referred to as the vestibular fold. There's that word again, vestibule, the opening into, the entryway into. The lower fold will be over your true vocal cords. And when I show you the video in a moment, and I'll show you this again from a different view, that'll become more clear. Any questions on this mid-sagittal cut of the head? Okay. Going down now, here's another view of the sinuses, and I think from this view, you'll appreciate that you have 4 pairs of sinuses, frontal that we've seen, and sphenoidal that we can see in the model. What you were not able to see were these green-colored ethmoidal or the red-colored maxillary. They are too lateral. They're too far off from the side, therefore they're not visible on your mid-sagittal section. So, do you need to know them? Yes. Can you label them on the models? No. Okay, so you decide how to interpret that. It wouldn't be a proper answer on any of our lab exams because I don't have a picture of that. I don't have a model of that. Going down, we know the pharynx is your throat. It is used by both your digestive system and your respiratory system. We saw this image a couple of weeks ago. I had you already look at and add to your list the nasopharynx. So now you appreciate, we already know that. We don't have to worry about that term anymore. Now, going down, let me show you the larynx. You have the larynx and the trachea on a stick there in front of you. So this is just a different representation of the same structures. The epiglottis sticking out of the top, I got that. The Dracula teeth, that's your hyoid bone. That's also on your model. It's in white. What else you need to know is there is a big chunk of cartilage called the thyroid cartilage. Very obvious, big chunk. There's also a second piece of cartilage, rather large, called the cricoid cartilage. Those are the only 2 that you need to worry about. Your pictures and this have other ones, the arytenoid and other cartilages, but you don't need to worry about any of those. Just the 2, the thyroid cartilage and the cricoid cartilage. Below that are the C-rings. They are literally C-rings, horseshoe-shaped chunks of cartilage, and they're going to keep the trachea open, not let it to close down. Now, over here on the side, I know it's not really easy to see. I'll show you a different view in a moment. These are your 2 vocal ligaments, if you will. The upper one, you see over here, it's called the vestibular ligament or the false vocal cord. It's the upper one. The lower one is your true, there it is, your true vocal ligament or your true vocal cord. So that's what's important from that model. Now, if you could take away, and everything I'm saying is printed here for you, if you could take away all the muscle and the skin layers of the larynx, this is what would be left behind, just the cartilage and the ligaments. So the biggest piece of cartilage, right, that's your big thyroid cartilage. The second piece of cartilage is the cricoid cartilage. Also in here, imagine all the muscle and all the tissue has been taken away. Here are your 2 vocal ligaments, sort of like 2 guitar chords or 2 piano chords. If they were thick, they'd be a bass. If they're thin, they're going to be a soprano, a very high frequency pitch. When they're next to each other, as we have here on the left, imagine air is coming up from your lungs and it's vibrating past those strings and it's causing sound. When you open your vocal cords, as shown here on the right, now you're breathing without making sound. Right? So we open and close those vocal cords, they vibrate, they produce sound, and I'll show that to you in live video in a moment. Then, 2 more pictures or so to share with you. Here we've got the trachea. So on the top, there's the larynx, the voice box with the thyroid and cricoid cartilage. Then these variable numbers of C-rings, depending on how tall you are, somewhere, I don't know, up to 15 or so of those C-rings. Where the trachea splits is called the carina. Right, you'll see that word in your list, carina. I remember that when I have a sister-in-law who has sort of a split personality. Her name's Karina, sorry. So I remember that easily. The heart is sitting right here, right? On the left side. And so the left lung has to make room for the heart. And so the left primary bronchus makes more of a horizontal shift. The right side doesn't have to make room for the heart, so the right primary bronchus does more of a direct downward movement. Also notice the radius is bigger of the right side than the left side. And that is, as you're looking at your models, you appreciate the left lung only has two lobes. Right? The left lung only has two lobes, superior and inferior. The right lung has three lobes, superior, middle, and inferior lobes. So if someone's going to aspirate, that is, they're going to bring food or a penny down the wrong pipe, and rather than swallowing it, it goes down the larynx and into the trachea and in the lung, which side is it more likely going to fall? Which side? Kerplunk, right? Straight down, right? Straight down. It's bigger and it's straight down. So if you're going to aspirate food down into your lung, more oftentimes it's going to go down into the right lung. Now what happens to that rotten food? That food that goes down into your lung. The bacteria are going to come and eat it, right? So you're going to have an infection, you're going to have pneumonia, what they call aspiration pneumonia. So when people are usually a little bit more frail, if you're healthy and you start choking and food's going down the wrong pipe, you're more than likely going to cough it up. It's going to get to your vocal cords and you're going to cough it up, right? It's never going to get down there. But if you're weaker, or you've got a swallowing issue, or you've had a head injury or a stroke, and you've already got issues with the coordination of your swallowing, you're more likely going to have that food kerplunk down into the lung. You've already got some medical issues, and now we're adding to it pneumonia, right? And this happens quite frequently. So we have to prevent that by helping people not swallow things or aspirate things down into their lungs. In the histology of this is what you would see. Big, open tube, right? So there's your big open lumen of the trachea. It is held open by this, in this case, the yellow is your C-ring. There's your C-ring of cartilage, and it keeps that trachea open. Next week when we do the dissection of the trachea, you're going to be able to feel how it's truly a horseshoe-shaped or C-ring shape of cartilage. On the back side, there's your esophagus. Right? So that's a totally different tissue or totally different structure traveling down the posterior side. What kind of epithelium is lining your trachea? Lining your trachea, lining your respiratory tract. There it is. Good old pseudostratified columnar. Remember we talked about that a long time ago. What kind of epithelium is lining your esophagus? Protects you against scraping off too many layers when you're eating a Dorito. Stratified, squamous, non-keratinized. Remember, keratinized only in your skin, non-keratinized in your mouth and down your esophagus, anus, and vagina. Okay, last picture. This is just like your image on page 518. Now, while you don't have an image, not this one, sorry, jumped ahead. This picture reminds you that there's a big chunk out of your left lung called the cardiac notch that makes room for your heart. Therefore, your left lung only has 2 lobes, whereas the right side, 1, 2, 3 lobes. Okay, it's bigger. There's more air going to your right side than the left side. The number of secondary bronchi. Somebody asked me about primary and secondary bronchi. The primary bronchi are the major branches coming off the trachea, right? Then the next branching would be your secondary bronchi. There are as many secondary bronchi as there are lobes. So that means on the left side, only 2 secondary bronchi. On the right side, 3 secondary bronchi, 1 secondary going to each lobe of the lung. So look at this image. I know it's small, but there's something wrong up here. What is wrong with how the artist put this figure together? Here's your heart. That would be the left side, and it looks like there's 1, 2, 3 secondary bronchi. That's inaccurate. So this image is a little bit off. Okay, it should only be 2. And over here on the left side, they have 2. So it looks like they reversed it. Somehow in the artist rendition, the artist didn't take my class. Now finally, this is page 518, essentially. Page 518. And remember that last week we talked about capillaries. And we learned that typically red blood, right, travels down an arteriole, goes into a capillary, there gases are exchanged, oxygen's dropped off, CO2 is picked up. So in your typical capillary, we think of the blood going from red to blue, and then that blood returning through a series of veins to the heart. Remember in the lung, everything's reversed on us. So that means that blood is coming to the heart in a blue artery, right? It's being pumped out from the right side of the heart. It's going to the lungs as part of the pulmonary circuit. Every one of your little air sacs, every one of your little alveoli has its own little capillary bed around it. But look what this capillary bed is doing. It is going from blue to red, right? Because what's happening here? You're dropping off the CO2, you're picking up oxygen, and then, so that capillary is going from blue to red. Everything's backwards in the pulmonary circuit. And then that blood's going to leave the lung through a series of pulmonary veins, which are red, going back toward the left atrium. Okay, so just keep in mind, everything's reversed in the pulmonary system. So with that, I'm going to bring us now over to YouTube. Those are my only videos to share with you. And I'm going to bring us to YouTube. I've never tried to record a YouTube video while watching this, or while recording this. Let's see how this works. And I'm going to go over and I'm going to type in vocal cord quartet. And what you're going to see here is 4 individuals, 4 split screens, and it's an alto, soprano, tenor, and bass. And they are going to have a laryngoscope placed down their nose. As you see it, you're going to see it traveling and going through their nares and through the meatus, and then you're going to see it come up right above the vocal cords. You're going to see the epiglottis and the vocal cords. Then they're going to sing this beautiful aria, and you're going to be able to appreciate that when the vocal cords separate, they're breathing. When they're together, they're singing or speaking. And thicker chords would be a bass or tenor, and the thinner chords would belong to the females. And this is why Mama sings bass right after she smokes for 20 years. So smoking irritates those vocal cords and makes them thicker, and they become thicker so that voice starts to lower as a result. So let's watch this little video. I think you'll enjoy it. So here's the soprano. Here comes the laryngoscope through the nares. Now notice how it looks like it's going through a tube, right? Through a narrow passageway. That's the meatus between the concha.
Oh, that would feel so weird.
Typically you would be numbed up a little bit. They would spray a little bit of numbing spray into your nose so you wouldn't feel it, it wouldn't be uncomfortable. And then all of a sudden, as they go down, nasopharynx, oropharynx, now you're suddenly going to see their epiglottis pop up, and you can see their vocal cords. Right above it, that'd be the false vocal cord, that little patch.
I don't like that.
Hold on. Hold on. I should be hearing this. Here we go. Out comes the tube. Comes out a lot faster than it goes in, doesn't it? They did an admirable job considering they had a tube down their nose, right? To sing that. Nicely done. So again, if you want to just look at that again, go to YouTube, type in vocal cord quartet, and you'll find it. Also around there, you'll find Steven Tyler's vocal cords when he's singing, all kinds of some interesting vocal cords that are fun to look at. So with that, look at your list right now on page 519. Is there anything at all on that list that you are now not able to identify? We feeling pretty good about respiratory structures?
Better than the other ones.
Good. So next week you'll come in masterfully ready to give a little quiz, take a little quiz on this. Now, right now you need to switch out your models. If you're done with respiratory, and now you need two models in front of you. You need the urinary model and the triple paneled kidney model. And the trachea on the stick, the sagittal head, and the lungs can go off to the middle table or to someplace out of your way. Lots of room on the middle table today.
I just got disappointed today on my phone. It is. Hey, it's so disappointing.
And what I am going to do is have you turn to the urinary system. The list will be on page 598. The images thereof will be a little bit before that. You also want to have your PowerPoint. So I'm actually going to walk through these PowerPoints with you. And I'm going to go through this very deliberately so that when we're all done, you should be pretty confident on the structures. Now, by going through this more slowly, it won't leave a lot of time at the end to review the models, but we'll be doing it as we go through this. And you probably will want to find some time over the next week to come in, take a few minutes looking at the models in 249 or simply looking at these same model images online or on mastering. And then finally at the end, just because we never have enough time in this lab to actually do the dissection, I will show you what the kidneys look like when you cut into them, and I'll show you a specially prepared kidney, and I'll walk you through that when we get done. So these notes are directly out of your PowerPoint. So the urinary system is going to be the system that you know filters your blood. And what it's filtering is the plasma of your blood, right? The liquidy portion of your blood. But as we discussed last week, the plasma of your blood is in constant exchange with your lymph or your interstitial fluids. So effectively, your kidneys are filtering your blood and your lymphatic fluid, and it's doing this 24/7, constantly filtering the waste products out of your blood. Without your kidneys, you're dead within a few days. So very, very important organs. The gross anatomy here is very simple, I think. You got a couple of kidneys, right, most of us. From those kidneys where the urine is made, the urine's going to travel down a couple of very muscular tubes called the ureters. Those ureters are going to dump into the bladder. The urine will be stored there for a short while and then released through the urethra. Collectively, this is your urinary tract, and if you have an infection of this, you would have a UTI, urinary tract infection. So let's take a look at this image. It looks a lot like your model, and there's a couple of things on here I want to point out, but even before that, I want you to remark or imagine how this is different than what you would see if you simply did a cut into your abdominal pelvic cavity, or even when you open your fetal pigs. Is this what you saw?
No,
No. What's been removed?
the digestive system.
Yeah, all the digestive system, the stomach, the large intestine, the small intestine, the pancreas, all that's been removed. And something else has been removed as well. When you, even next week, when you do your fetal pig dissection and you take the intestines and the stomach out, and you will do that, you'll see the little kidneys back there. But you won't be able to touch them directly yet because you're going to have to go through one more layer, and that layer will be the peritoneum, that abdominal pelvic serous membrane that we've talked about. Once you get rid of that, then you'll be able to directly touch the kidneys. So that's all been removed here. So what we have, we see a couple of kidneys. On top of the kidneys, the two adrenal glands, one on each. We can identify the vessels, right? Here's the inferior vena cava and the aorta. Even here I see the common iliac, the little internal and the external iliac. The two kidneys, I see the renal vein, the renal artery going to the kidneys. Leaving the kidneys, the ureter goes down to the bladder, dumps into the bladder, urine is released through the urethra. This is a little girl model. I see a little uterus, non-pregnant uterus. I see the fallopian tubes, and I see the ovaries that we'll deal with next week in the reproductive labs. I also see a couple muscles as a review. Coming straight down from the abdominal pelvic area, that muscle is labeled for us. That's the psoas major. Remember that one? We only saw it on our leg muscle model. And the muscle that's filling up the ilium is what muscle? Iliacus. Remember this? And those two muscles would come together, and right about there on the muscle, we would have said that was the iliopsoas. So I bring that back to remind you that you can't forget anything. I won't be directly quizzing you on that this semester, but when we get to 106 and we get to the muscles, we will not spend time reviewing what you should already know. We'll be going to different muscles, and we will expect you to know the old stuff. So you don't want to throw anything away from your Amerman book. Your Amerman book is gold, and you know it well, you've studied from it, and you definitely want to hold on to it as a resource. And next semester, you may not be asked directly to bring your Amerman materials, but you're going to find yourself, I think, going back and looking at it as a review. So don't lose it. Don't throw it away. Don't do like the last day of school in high school. We throw everything out the bus window, right? Hold on to it. Keep it. You're going to want to use that. Now, the functions of the urinary system are familiar to you. We know that we're filtering the blood and we're storing the urine. But there are two other functions here that you may not be fully aware of or don't think about. The fourth bullet here, we definitely are helping to regulate the blood volume and ultimately your blood pressure with the urinary system. So if you have high blood pressure, one of the medicinal, pharmaceutical ways to help regulate blood pressure is to give patients a diuretic. And a diuretic is a medication that's going to make you urinate profusely. You take the pill and 30 minutes later you're in the restroom. As you're urinating, what are you getting rid of? Water, urine, but that urine is really plasma, right? You're losing blood volume as you create more urine. And as you reduce that fluid from your blood, you're also going to be reducing the pressure of your blood. So diuretics are going to keep that fluid off your body and reduce your blood pressure or help maintain it at a more normal rate. The other thing that your urinary system is doing with you is helping to regulate your red blood cells. Now that connection may not make sense at first, but the kidneys are basically, as they filter your blood, they are indirectly measuring your oxygen levels. And if the kidneys say, looks like the oxygen levels are getting a little bit low, then they're going to release a hormone called erythropoietin. Now that word should speak to you. Erythro means what? Red. Poe. Formation of or making of something. And IN on the end tells us it's a protein. So this is a protein hormone produced by the kidneys. And it's going to tell your body to make more red blood cells. So what would be the target? You guys are talking about endocrine system right now. What would be the target of that hormone? Made by the kidneys, targets the... Where do you make more red blood cells? Bone marrow, right? So this hormone is going to be released by the kidney, travel through your blood, go to a far, far away place, go to the bone marrow, and there influence the formation of your red blood cells. This hormone is given in the clinic. It's sometimes called EPO. People who are going through chemotherapy treatments are sometimes given this as a way of helping them get through that chemotherapy, because we know that chemotherapy preferentially destroys your red blood cells, makes you very weak, very anemic. And so these patients are given EPO, and that will hopefully at least keep their blood levels up so they're not quite so wiped out during the treatment. Now the kidneys, just a quick story about the kidneys. They are said to be retroperitoneal. That is true of the entire urinary system. That is, they are behind the peritoneum. I already showed that to you in the picture, that when you open up your abdominal pelvic cavity, you won't be able to touch directly the kidneys without first popping through that layer called the peritoneum. The kidneys are kidney-shaped, right? We know that. And there's an area of the kidneys, right, there's your kidney. This little indented area is called the hilum, what we call the concave border, what goes inward. And the hilum is a term that means where everything goes into or out of a structure. So the kidney's hilum is where the renal artery, the renal vein, and the ureter and other structures go into and out of the kidney. Now, if I had your kidney or a kidney in my hand and I tapped on the outside edge of it, I would be tapping on the fibrous capsule, also called the renal capsule. This is a dense, regular connective tissue layer. Then there'd be a layer of fat called the perinephric fat. That should make sense. Perimeter. Around the kidney, there's a layer of fat. Then there's a layer, very thin, called the renal fascia. I think of it as a layer of saran wrap. If you could imagine saran wrapping your kidney and adhering it to the back of your abdominal pelvic wall, there'd be a layer called the renal fascia that would be like that saran wrap layer. And then another layer of fat called the perinephric fat. Now, this fat's important. It's not in our models, but this fat's important because it protects the kidneys. The kidneys don't have the benefit of a skull or the benefit of a rib cage to protect them, and they're a very important organ. So they have some extra fat around them to help protect these critical organs. As you cut into, flail open the kidney, what you would notice is like any other solid organ, the outer layer, just like the brain, is called the cortex, and the inside meaty middle would be the medulla. Same story. When you're in the middle area, in the medulla, you would notice that it's divided up into a variable number of pyramid-like structures. These are called the renal pyramids. You have between 8 and 15 of them in your kidneys. And all of those pyramids would be pointing their apex, their tip, toward the center of the kidney. In those pyramids and in the cortex, there is a vast network of microscopic tubes. And those tubes are going to be the urine-producing structures that we're going to talk about in a second. And they're all going to be pointing toward the center, and eventually that urine would then flow down to the ureter and to the bladder. So here's a picture. It looks like your big elephant kidney on your triple panel. And all you really need to appreciate here is, if I knock on the outside, that's going to be the fibrous capsule. The outer layer that's shown a little lighter color, this bracketed area, would be the cortex. Everything in the meaty middle would be the medulla. And what I note is that the medulla is divided up into these pyramidal structures. And all the pyramids are pointing toward the center. Okay. This would be the hilum area of the lung. Sorry, that's a funny looking lung. The kidney. And that's going to account for where the renal artery goes in, the renal vein comes out, and where the ureter comes out of the kidney. So the gross anatomy is not too hard. And when I show you the kidney sliced open, you're not going to be very impressed. It's just not as visually stimulating as the images are. So we'll look at them briefly at the end of the hour, but you will have seen better pictures in the models and the cartoons. Now, you know that the last 3 or so quizzes have all been about the flow of something through the body. We had the flow of blood through the heart. We had the flow of food through the digestive system. We've been talking about the flow of blood through the arteries and veins of the body. Now we've got to keep track of 2 flows in the kidney. Number 1, the flow of blood. Right? We know the kidneys are filtering your blood. So blood has to come into your kidneys, be filtered, and then leave. So we got to figure that one out. Then we have to figure out, once we filter the blood, where does that stuff go that becomes our urine? What's the flow of that filtrate stuff? So we'll start off with the blood flow. Pretty straightforward. I'm going to try to make it more simple and drop out some of the details. So we've got a kidney shown here. It's been opened up, and blood is coming into the renal artery that we see here. Now you know that arteries keep getting smaller and smaller and smaller. And there are names for those branched smaller arteries that we're going to skip over. So we're not going to worry about segmental interlobar, arcuate, or interlobular. Not even worry about those names. Where we are going to pick up the story of blood flow is at a small microscopic vessel called the afferent arteriole. Now, what does afferent tell you? Afferent neurons were the sensory neurons, remember? And those sensory neurons are going inward, right? They're going toward the spinal cord and toward the brain. So afferent tells you incoming, it's coming in. Arterial tells you that it's a very small artery, right? So this is a oxygenated arterial, small artery, bringing blood into the fine structures of the kidney. Where that afferent arteriole is going is to a ball of capillaries called the glomerulus. The prefix glom refers to a ball-like structure. So the glomerulus is a ball of capillaries. And even from across the room, I'm circling two glomeruli, two ball-like capillary beds. Now it's here that the gases, back up. It's here that the blood is filtered. Okay? It's in the glomerulus that you're filtering out the waste products that will become the content of your urine. The blood comes out of those leaky capillaries, the glomerulus, and into the efferent arteriole. Now wait a second. I thought last week we said that blood goes into a capillary from an arteriole and comes out a small vein. But the kidney is different. Here, the blood goes in the glomerulus through the afferent arteriole and comes out the efferent arteriole. Efferent tells us what? Away from, going away from, exiting. Arterial tells us it's still an artery. And if we look at the coloring, it's still red. So this is a funky difference. It's a unique thing about the kidney. You've got blood going in and blood coming out of the glomerulus that's still red. So what does that tell us did not happen in the glomerulus? Still red. Say it again. The oxygen did not get dropped off. So the glomerulus is only about filtering out the waste products, not about gas exchange. Now, what's unique in the kidney is that after you come out of the glomerulus into the efferent arteriole, then the blood goes to a second set of capillaries. And these are your traditional capillaries where gas exchange does happen, and they're called the peritubular capillaries. Once gas exchange, right, we've already filtered the blood, we've already done our gas exchange, now we leave the kidney. We're not going to worry about the intermediate names of the veins, and we're just going to say, okay, now the blood leaves out the renal vein. So we're dropping off some of the intermediates. We're honing in right at the action place within the kidney. That is your blood flow story that you've got to keep track of for the kidney. So say it again with me. In the renal artery, right? Split, 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 unnamed. And we pick up at the afferent arteriole. The afferent arteriole brings red blood into a ball of capillaries called a glomerulus. In the glomerulus, what happens? Filtering of the blood, removing waste products. No gas exchange. We leave this ball of capillaries and we go out into an efferent arteriole, still oxygenated but without the waste products. Then that blood travels to a second capillary bed called peritubular around the tubes. We'll see what that means in a moment. That's where gas exchange happens. You see the model becoming more purple-like and then leaving out a series of veins, skip over the specific names, and leave out the kidney through the renal vein. Okay, so more goes into the kidney than what comes out, right? We're filtering, we're leaving some stuff behind that will become our urine. So that's the blood flow. Everything I've said there that's unique to the kidney is included in words on this slide. A lot of your blood goes to your kidney. 20 to 25% of all of your blood is going over to the kidneys to be filtered. This is going on 24/7. Your kidneys never stop filtering your blood. Yes, sometimes you have more output. Sometimes you are more hydrated, you have more output. And sometimes you're more dehydrated and your urine is more concentrated and dark. But regardless of your output, your kidneys are still working. They're still working 24/7, getting rid of those waste products. What you're filtering out is the plasma. It's being filtered in the glomerulus. And as I mentioned, what's unique about the kidney is that it's leaving out the efferent arteriole, still has oxygenated blood. So that's what's different or unique about the kidney when it comes to the blood supply. Now, we turn to the other story we have to keep track of, and that is, once we filter the blood, where does this stuff go and how do we create the urine? And now we've got the journey now of this liquidy filtrate. This is going to happen in a series of tubes collectively called the nephron. Okay, the nephron is the real working part of the kidney. And the nephron is defined as being four different parts of a tube. There's a renal corpuscle, then a proximal convoluted tubule, what's referred to as the nephron loop, and then the distal convoluted tubule. If I could stretch that little bit of tubing out, it would be about 5 centimeters in length or 2 inches. So that means you've got about 5 million inches of tubing because you've got about 2.5 million of these nephrons squeezed into your 2 kidneys. You've seen this before. Back in lab 3, histology lab, I showed you a particular arrangement of epithelium, always in a circular arrangement. And that should get you thinking about that visual picture. And that was always simple cuboidal. And that circular arrangement I was showing you was from the kidney. It was from the tubes of the kidney where this filtration story is happening. It turns out there are 2 types of nephrons. You'll learn a lot more about this next semester, but one type, cortical nephrons, sounds like they're more in the cortex. And the second one, juxtamedullary nephrons. They, as the name suggests, are next to or closer to the medulla. And we'll figure out what the difference in those is next semester. Let me go through each part of the nephron. First part is the renal corpuscle. That is what you have in front of you on your triple model. So each of you has, on your triple model, you have a renal corpuscle. That renal corpuscle is this portion, right? This is the renal corpuscle right here. What it's made up of is the glomerulus, the ball of capillaries inside, and what protects it and holds it is this structure called the Bowman's capsule. So this is the Bowman's capsule plus the glomerulus. Collectively, this is a renal corpuscle. Now, this would normally be enclosed. So this little Bowman's capsule has been sliced open for you to see this. It would normally be bulbous and closed in. Okay? So that's the renal corpuscle. And what's unique about that is that that glomerulus is a ball of capillaries. And these capillaries, as I told you, are filtering. Well, in order for them to filter, they have to have little holes in them. So these are leaky capillaries. They've got a bunch of little holes in them. And those holes are what we call fenestrations, or these capillaries are fenestrated. Last week I tried to convince you that capillaries are very, very delicate. Right? They're just one layer thick, right? They're very thin. And now I'm telling you that these capillaries also have holes in them. This sounds like very delicate lace, right? It's not a very strong structure. So to give these capillaries extra support, there are cells in the neighborhood called podocytes. These cells have what? They have pods. What's a pod? You go to the podiatrist, right? Foot-related issues. So the podocyte is a cell with foot-like extensions. And those foot-like extensions are going to wrap around these capillaries, giving these very delicate, holy capillaries some extra support. And this is what it looks like in this cartoon. Now, even your model in front of you shows you these podocytes. Here are a couple of the capillaries. Notice that these capillaries have very small holes in them. Those are the fenestrations. There's the word. In order for small molecules to get out of your blood and end up in your urine, they have to be small enough to go through those little fenestrations. But also, here's the podocyte. There's the nucleus of the podocyte. It has these foot-like extensions that wrap around the capillary and create another layer of what's called filtration slits. So that means that a molecule that's going to come out of your blood and get into your urine must pass through both the fenestrations and these little filtration slits. Beautiful. Isn't this a cool electron micrograph? You're looking at the fine, delicate structure of a podocyte wrapping its little foot-like structures around capillaries of the glomerulus and creating all these little filtration slits. Really a very intricate, beautiful picture. But what do you think happens to a person who has high blood pressure for 20 years? What happens to these little fenestrations in the kidneys glomeruli? They start getting bigger. And now, with that high blood pressure, when they do a urinalysis, they start seeing things in the urine that shouldn't be there, like proteins. Lots of proteins start showing up in the urine. Proteins normally, some might get through those little holes, but most of the proteins are being kept inside the blood. They don't get out through the holes. If you got really bad kidneys, you might even start seeing blood cells showing up in your urine, right? And that's not, I mean, certainly that blood cell should not be getting through those little holes. Let me give you just an image of this. This capillary would be somewhere between 8 and 10 microns across, micrometers. Red blood cells are going to be about 7.5 microns. So a red blood cell will be about this big. There's no way a normal fenestrated capillary should allow that red blood cell to get through that little hole. But with enough time and enough high blood pressure and another kidney disease, those fenestrations get blown open, and now you start seeing red blood cells in the urine. Now, by the time that happens, the kidney's in a lot of trouble. It's a mess. And the body's no longer filtering things the way it should, and this person's probably going to be on dialysis because their kidneys are not doing their job. This image would be a renal corpuscle, right? This whole thing would be the renal corpuscle. And what do we see here? Blood coming in, afferent arterial. Comes in, goes into these leaky capillaries. You can even see the podocytes around those capillaries. Small molecules and water would be filtered through those holes and would gather in this space called the capsular space. And then start going down this tube, the proximal convoluted tubule. What does not get filtered out of the blood would leave the glomerulus out the efferent arterial. Okay, and then go on to the second capillary bed. In what you have in front of you, this represents the frying pan handle, right? So you see that little handle-like structure coming off your renal corpuscle, and even in your model, it reminds you that that is lined by simple cuboidal. Even look at the model. It looks like a layer of simple cuboidal cells in the model. Okay, everybody see that? Now under the microscope, and you've seen this before, when we looked at kidney, this is what it looks like. You see this lollipop structure right here? That would be the Bowman's capsule. Everything inside of it, therefore, would be the glomerulus. Outside of it, tube, 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 tube. Remember I told you there's 5 million inches of tubing squeezed into your kidneys. So this is a very densely packed area of tubes, all lined by simple cuboidal. Now let's start that journey down those tubes. Once the filtration occurs at the renal corpuscle, then the filtrate is going to go down the proximal convoluted tubule. You'll see it abbreviated, the PCT. Now we've got a problem here. In order to get rid of waste products, the kidney is constantly filtering out your blood. That is a passive process. A lot of water is also going through those little holes, as well as glucose and other important molecules that the body would not want to just flush down the toilet. So the body needs to get back many of those important molecules. So in the proximal convoluted tubule, the kidneys are going to reabsorb most of the nutrients. So the glucose, the amino acids, the small proteins, things that did squiggle through the fenestrations are going to be taken back up by the body. All that's going to continue then would be a little bit of water and the waste products, right, down the tube. Most of the water, right, 2/3 of the water is also going to be reabsorbed in the proximal convoluted tubule. You'll get more of that in lecture. For today, I'm just dealing with structure, right, but that's happening in the proximal convoluted tubule. Then you go down the nephron loop. Now this was described by a guy named Henle. So the loop of Henle is called, the nephron loop is also called the loop of Henle. What happens here I'm not going to get into right now, but I'll show you where that is in the picture in a moment. And then once you get past the nephron loop, then you get to the distal convoluted tubule. Now when I say the word distal, what comes to mind?
Furthest away.
Furthest away, right? Distal versus proximal. So the proximal tubule is close to the renal corpuscle. The distal convoluted tubule is further away. And the word convoluted means what to you? Man, Allie, that is a convoluted argument. Twisted. Doesn't go in a straight line. It's not going from point A to point B in a straight way at all, right? Convoluted, twisted. So this is a tube that's twisted, some of it on the front end, proximal, some of it on the other end, the distal. In the distal tubule, I just want you to circle this word secretion. We'll talk more about it in lecture, but you'll have heard that word secretion when you get there. The only other thing I want to say about the distal convoluted tubule is, since you're talking about the endocrine system, have we talked about ADH at all? ADH, antidiuretic hormone? A little bit? Okay? So what does a diuretic do? A diuretic makes you go to the bathroom, right? More often. So an antidiuretic hormone would be a hormone that told your body to stop, hold on, concentrate your urine, don't let it go. A lot of that's going on. Your brain is telling your body to release or not release, concentrate or not concentrate your urine. So I'll just say to you that the kidneys are directly affected by ADH. And that's a hormone you probably heard of in passing, and you'll talk more about in next semester for sure. Now, this cartoon represents basically a pyramid, right? So here we got up here in the top picture, that's basically a pyramid of your kidney in 2 dimensions. This is a very simplistic representation. Here is the glomerulus. Do you agree? The ball of capillaries. Once the blood is filtered, it's going to start going down the proximal convoluted tubule, twisted tube. During that twisted tubing, there's going to be a lot of resorption of the water and the glucose and the good stuff. Then, what's left is going to take a nosedive down the loop of Henle. Down and back up. Nephron loop or loop of Henle. Then it's going to come up on the other side, and now it's in the distal convoluted tubule, or another twisted tube at the other end. And then eventually, the distal convoluted tubule will dump into a collecting duct. Now, the collecting ducts are not officially part of the nephron. As you'll see, there are many nephrons dripping into collecting ducts. Now, the collecting ducts are all going to focus down toward the apex, right, the point of the pyramid, and then drain into a tube called the minor calyx. And you'll see that in the labeling. The minor calyx, a little tube-like structure that's going to collect the urine. Now I'm going to jump over some of this. You can read about it. Again, my focus today is on the structures. So we've kind of gotten through the major structures of the kidney. Now what happens to that urine? It's going to travel down the ureter and go down to the bladder. So read about it a little bit. But here's a bladder. Here are the ureters coming down from the kidneys. Here is the bladder itself, kind of a little oblong shape. And here are the openings for that urine. So the urine comes down the ureters and drips into the bladder through those openings. As the bladder begins to fill, pressure is put down on this sphincter. This is the same story as what you had in the anus. There were 2 sphincters. Remember, the internal and the external. The first sphincter is going to be the internal urethral sphincter. As the bladder fills, it's pushing down on this muscle. The muscle senses it and gives you the urge to go. Then, a little further down the urethra, here, is the external urethral sphincter. This is voluntary muscle, skeletal muscle. You have control over it. This is your toilet training muscle. Okay? That's all I'll say about that structure. Now let me look at this again with you. In the female, again, this is female, bladder, Ureters coming down, dumping into these openings. Internal sphincter in this area. External sphincter found a little further down. Urine coming into the labia. Okay, that's female. There's a relatively short urethra, which is what allows women to have more urinary tract infections than guys, because it's not a very long distance from the outside world into the bladder. We'll talk more about the male again next week, but let me just show you the male system. We'll finish up on this image today. So here's the male bladder. Same old bladder. There's your internal sphincter right there. But, what's this thing? Prostate gland. Okay? So the prostate gland is sitting right there, and the urine is going to drain through the urethra right down the center of that prostate gland. Then the external sphincter is right here. And then the rest of the urethra passing through the erectile portions of the penis. So what happens to guys normally over the age of 50? The prostate begins to enlarge. And what are Grandpa Joe's complaints? He can't pee, or he has to go all the time. He gets to the restroom and nothing's happening. Or the flow is inconsistent, or maybe he even loses control over urination a little bit. So let's figure that out. So as the prostate enlarges, what if it's pushing up here? It's pushing on the internal sphincter. That guy's going to have the urge that he's got to go, as if his bladder's full, but he gets there and nothing happens. The bladder's not really full, but he has the urge. He thinks that it's full. Or what if it's pushing down on the external sphincter? You might have an accident. You may lose control over your urination. Or what if the sphincter, or as the prostate's enlarging, what if it's narrowing this urethral opening? Flow would be inconsistent or stop and go. So you've got, the urge to go, but nothing's there, inconsistent flow, or accidents and lack of control because that prostate is interfering with these sphincters or the urethra. Now look at your little urinary models and tell me, do you have little boy models or little girl models? Take your bladders out and tell me what you have. Little boys, little girls. You have a girl? I hope not, because that little girl has a big prostate on her bladder.
Oh. No.
Okay? Everyone see the prostate? Okay? So all these models are little boys. Okay, they all have a prostate gland. Right? That's a big old prostate gland.
Oh, right there.
Okay? See it?
Yep.
So here you go. These two things coming down, these are the two ureters. The urine's going to drip into the bladder, open the bladder up, and you'll appreciate that the urethra passes right through the center of that prostate gland. Now, when you look at this model, I know it's really tempting to think, oh, here's a little boy standing at the urinal. And this must be his urethra. No. Okay? This is a little ligament, it's not even on our list. The urethra goes through the prostate, and these poor little models can't urinate. They did not create an opening or a possibility, so these guys can't urinate. It's not a very good model of the urinary system. They can't do their job, is it? So, I think I went through that deliberately enough with you. If you have any questions, I'll be glad to address them. Otherwise, turn to page 598. And on page 598, you're going to find your model inventory list. You were instructed to cross some things off earlier. Who has those things crossed off? Would you kindly read out the things that are crossed off?
Blood supply, olive A.
So under, is it 5A?
4.
4A. In other words, all the individual arteries, right? We're just going to call the renal artery, but we're going to get rid of all the intermediate names, right? And then also the veins.
Yep.
Under number
4B.
4B, right? Those individual names of the veins are getting crossed off. And then under
structures of
nephron,
3.
which is the juxtaglomerular apparatus, cross that off. And also cross off the,
3 and 5.
and what are they, read them for me.
It's the papillary duct.
Papillary duct, right?
So we can cross off all of 3, the A and D.
Yes. And then finally you're going to cross off
Under urinary
and they are the
urethral
urethral orifice,
and the internal urethral.
internal urethral orifice. So cross those off, and everything else you should be able to appreciate from the models, and I'll be glad to help you with that.